Friends, welcome back to another session on RA Simplified series. Today we will discuss the second chapter of RA4, that is Precursor Myeloid Neoplasm, Recent Insights. Although I am little bit uncomfortable using the term neoplasm in this chapter, but it is what it is. Why I feel so? Because as we will see in this chapter, these entities are not yet neoplasm. And so same thing is also informed by WHO, as we will see later on that WHO uses the term myeloid precursor lesions. But anyways, so I have prepared my notes from two books. One is RA4 Hematology and another one is WHO Classification of Hematolymphoid Tumors, 5th edition. Since this chapter is best described in WHO, I have incorporated some extra points from WHO also. So my outline would be an introduction which will be predominantly from RA4. Then I will briefly discuss the WHO classification of myeloid precursor lesions. Then we will discuss each entity that are described in this category MPL, that is myeloid precursor lesions, in WHO one by one, that is clonal hematopoiesis introduction, then clonal hematopoiesis, then clonal cytopenia of undetermined significance. That chapter is best described, as I mentioned earlier, the chapter is best described in WHO, so I will cover extra points from WHO also. And lastly, we will go back to RA4 notes again, and we will use a comparative table of CHIP, ICUS and CCUS from that table, and management and follow-up of MPL. So that would be my brief outline. Don't worry about these newer terms such as CH, CCUS, ICUS. We'll cover each one of these and we'll understand what these terms mean. So let us begin the chapter with the introduction. So precursor myeloid neoplasm, these are nothing but hematological disorders which exhibit abnormal proliferation and differentiation of myeloid precursor cells in the marrow. Now they act as risk factors and precursor for AML and other related diseases such as MDS. WHO 2022 and ICC 2022, both the latest classification of hematolymphoid neoplasm, they are based on morphological, immunophenotypic, molecular and cytogenetic details. The updated classification of hematolymphoid tumor contains a significant change in the myeloid neoplasia group, and under this change, for the first time, precursor lesions have been incorporated as a distinct entity such as clonal hematopoiesis of indeterminate potential, clonal cytopenia of undetermined significance. So this is the WHO classification of hematolymphoid tumor, 5th edition. So as I mentioned earlier also that the lesion is named as, the category is named as myeloid precursor lesions. Under this category or under this heading, they have created two entities such as clonal hematopoiesis and another one is clonal cytopenia of undetermined significance. In the heading clonal hematopoiesis, as you can see, there are two subcategories. One is clonal hematopoiesis of indeterminate potential and another one is Vexas syndrome. Now these terms, clonal hematopoiesis is everywhere written in short as CH. Next one is clonal hematopoiesis of indeterminate potential. It is named as CHIP, that is CHIP. And lastly, clonal cytopenia of undetermined significance. It is named as CCUS. So now let us go through each one of these one by one. So before starting the clonal hematopoiesis per se, let us go through a brief introduction. It is an introduction chapter given in WHO. I have created an important point notes from that chapter only. So clonal hematopoiesis. The term clonal hematopoiesis, it is a broad term and it applies to numerous entities. Several terms have been introduced to describe the clonality detected in people without diagnosed hematological disorders. So these terms are summarized in a WHO table. So I have used this table as it is. You can read the description by pausing the video or reading from the notes, but let me explain you this table in a simplified way. So first term is clonal hematopoiesis. So it is a clonal outgrowth of hematopoietic stem cell. From the affected stem cell or progenitor cell, this outgrowth occurs and it is regardless of cause or disease state. The next term is ARCH, that is age-related clonal hematopoiesis. So it is nothing but, if I can write it in a summarized way, then I can write it like this. It would be clonal hematopoiesis plus aging. So another factor that has been added here is aging. Now there should be some negative finding which shouldn't be there to define ARCH. What are these? There shouldn't be any hematological disorder. Then another negative finding would be there shouldn't be any cytopenia. And lastly, there shouldn't be any specific gene alterations. Now, if you will read this description, it is saying the same thing, but I feel it is easier to remember if we read it like this. The next term is chip. As I mentioned earlier also that the full form of chip is clonal hematopoiesis of indeterminate potential. So what is its description? So clonal hematopoiesis of indeterminate potential is again CH, that is clonal hematopoiesis plus somatic mutation, somatic mutations of myeloid genes with VAF more than equal to 2%. Now there are again some negative finding also. The first one is again there shouldn't be any hematological disorder, or there shouldn't be any unexplained cytopenia. We will cover this heading chip, CH, that is clonal hematopoiesis, and CCUS in detail also, where we will go through the all of the criteria mentioned. For example, this cutoff of VAF more than equal to 2%. It is not an entire criteria. We will discuss this criteria in detail when we will discuss chip. But the brief summary is this. The next term is CCUS. CCUS can be described simply as again clonal hematopoiesis plus at least one or more than equal to one unexplained cytopenia. Again, there are some negative findings. These are it should not meet diagnostic criteria for defined myeloid neoplasm. The last term is ICUS, that is idiopathic cytopenia of unknown significance. So it means that there is sustained and unexplained cytopenia, but the cause is not known. So that negative finding is there shouldn't be any blood cancer associated driver mutation. So this was all about the terminologies used in this chapter. Now let us go through each of these one by one. The first term is, or the first heading is clonal hematopoiesis. So clonal hematopoiesis, it refers to the presence of a population of cells derived from multipotent stem cell or a progenitor cell harboring one or more driver gene mutations. Now, what are these mutations? There is a huge table given in WHO. It is not possible to remember all of these in a PG level. So I have selected a few important genes. I will mention it in the criteria part. The next important point is it results in a selective growth advantage in individuals without unexplained cytopenia. So I have already mentioned what is the negative finding. Hematological cancers or clonal disorders. This term, clonal hematopoiesis, it was not included in WHO Hematology 4th edition or the revised 4th edition. In ICC, that is International Consensus Committee, it is not a separate entity, but it is described under or it is described with premalignant clonal cytopenias. Now it has two subtypes. One is CHIP and another one is Vexus syndrome. CHIP is clonal hematopoiesis of indeterminate potential, and Vexus syndrome, the full name is so it looks like it is an acronym. So the full form would be V for vacuoles, E for even enzyme, X for X-linked auto-inflammatory, and lastly S for somatic UVA mutation. So it is a recently described CH related disorder. Right now it is under clonal hematopoiesis only, but as WHO says that it is likely that in the next edition it would be a separate category. Localization of clonal hematopoiesis is under blood and bone marrow. The clinical features are CH is usually an incidental finding that is without associated any clinical feature, while Rex's syndrome has some clinical features, but we won't go into that much detail. Now the criteria, there are no defined criteria for clonal hematopoiesis, but WHO has defined essential criteria for CHIP, and these are, first one is there should be one or more somatic mutation with VAF of more than equal to 2% in the DNA from blood or bone marrow cells involving the genes. Now this criteria or the cutoff of VAF more than equal to 2%, it has been raised to more than equal to 4% for X-linked gene mutation in the males. Now, as I mentioned earlier, there are multiple genes associated with clonal hematopoiesis. I have selected a few of those. The reason for selecting these specific only is the first three, that is DNMT3A, TAT2, ASXL1 and PPM1D. They have some significant role in CH, which we will see later on. And apart from this, JAK2, TP53, SF3B1, we already read these genes in either MPN or MDS or MDS MPN entity. So it is easier to remember those. Lastly, IDH1, 2, we all know that this covers a majority of the CNS tumors. So we know these terms. That's why I selected those, although there are many more. Now, the first criteria is over. The next criteria is there shouldn't be any unexplained cytopenia. Lastly, there shouldn't be any diagnostic criteria for defined myeloid neoplasm. So, all of these I had already told you while describing the terminology. The next heading is epidemiology. Clonal hematopoiesis is a rare in individuals younger than 40 years. It occurs in elderly, that is aged more than somewhere around 65 years. It affects 10 to 40% of elderly individuals. Now, etiopathogenesis. Aging is the dominant risk factor for clonal hematopoiesis. The other associated risk factors are smoking, male gender, exposure to cytotoxic therapy, and aplastic anemia. Now, there are certain germline variants predisposed to clonal hematopoiesis. The mutation causing clonal hematopoiesis, they are often base substitution or small insertion and or deletion. Now, recent studies have shown that acquired chromosomal mosaicism is also increasingly recognized, and this has a poor prognosis, if you can remember. So let us continue. The next point is the selective advantage of a clone. It may be either gene dependent, it may be mutation specific, and it might be influenced by clinical context and timing of acquisition. There are frequent mutations which are present in clonal hematopoiesis. Now these three I have already mentioned. That's why I included in the criteria part also. That is DNMT3A, TAT2, ASXL1. Lastly, mutation in PPM1D and TP53, they allow the mutant cell to bypass cell cycle checkpoints after chemotherapy, resulting in a clonal expansion. There is no relevant macroscopic appearance. Even there is no known histopathological feature that correlates with CH or CHIP, that is clonal hematopoiesis of indeterminate potential. But the absence of features of defined myeloid neoplasm is integral to the definition of CS. So we should always rule out the defined myeloid neoplasm. That is the only histopathological significance. Now the next is diagnostic molecular pathology. So the diagnosis of CHIP requires detection of one or more of the somatic mutation in clonal hematopoiesis driver genes. These diagnoses are made by sequencing DNA from whole blood or purified blood cells populations. Non-sequencing approaches like flow cytometry or ISC, these are not recommended because they are not anyways diagnostic in this case. There is no relevant staging, and even in case of prognosis, there are only one or two lines that are I feel important are CHIP is a precursor state. It is distinct from hematological neoplasm. with a predominantly benign natural history. It has a malignancy rate of about 0.1 to 0.5 to 1% per year. Now, some mutations elevate the risk of progression. Most of these you already know. The mosaic clone has an increased risk of progression to leukemia. And lastly, CHIP associated with increased risk of atherosclerotic cardiovascular disease. So that's why we always assess the cardiovascular health when we try to follow up a case of CHIP. So this was all about clonal hematopoiesis and clonal hematopoiesis of indeterminate potential. The next heading is CCUS, clonal cytopenia of undetermined significance. But we will discuss this in a separate video. That's all for this video. Hello friends. If you have watched this video till here, it means you are seriously interested in learning recent advances. So I recommend you to check out my course on recent advances, where I have covered each and every topic of recent advances. And the best part about this course that I feel is I mostly make notes not just from one book, that is recent advances. I try to cover the topic from all possible books that we read during our MD preparation. So do check it out. The link would be in the description. And if you have any doubt, then my number will also be given in the description. You can WhatsApp me anytime. That's all for this video. Bye for now.